Sarel Gaur. Today we're going to talk about something that's very important, and that is when to say no to a procedure. This is an art, learning to say no, and it's just like saying no for anything else. No means no, and you have the right to say no. The problem with saying no is that at the time that you have to say no to a procedure, there's going to come a time when you're practicing, and you're going to have to say no to a procedure. At that time, there's going to be a lot of influence and a lot of people in your head telling you to say yes, and you're going to have to hear all this, that you should be doing this. I want you to do this. It's not right to not do this procedure, and you have to fight all that interference, and in your head stick to the answer of no, that no, you will not do it. And definitely, if you're in training right now, I think that you should engage your superiors on this art, or when do you say no to an interventional procedure. So yeah, the problem with saying no is that, kind of, as we're trained to be proceduralists, we're trained to kind of be approachable, affable. We want to be available. We want to please people, right? We want to be the nice guy. We want to help people. We want to help clinicians. They're in a bind. We want to do our procedures, and most of the time it's fine, because our procedures are safe, our methods are safe, and most of the time we have no problem. We'll actually get people out of a bind by saying yes. And obviously we say yes to even challenging cases because we enjoy the challenge. And again, we know from our training, we know from our experience that we're going to be successful. We often are successful. We can help patients, and we can become a go-to person in the hospital for managing crises. But at the same time, we have to realize when we're looking at a patient that we're unlikely to really be helping, and we're actually more likely to be potentially hurting and creating liabilities for the patient, and then therefore liabilities for ourselves. And one thing I'm learning as I'm getting older is that it's all about managing liabilities. If there's one thing you want less of, it's liabilities. And I'm always trying to figure out, how do I decrease my liabilities while maximizing my value? And it's you got to play two games. You got to maximize the value on the one end, and then you got to minimize the liability. You got to keep playing that game. And every single case I see, I'm just like, what is the potential liability? What is the potential threat of this case? And if the threat is too high, I simply exercise my right, my right as a physician, my right as an MD holder and a licensed physician in the state, to say I cannot offer this procedure. It is not safe. When I have to do this, I kind of do it a certain way, because you do it the wrong way, it just doesn't work. Well, the best way is you contact the physician directly and you have a conversation with them. Often that's not always possible because medicine is busy. Often when you try to contact the doctor, they're busy doing doctor things. So actually, this gives me a chance to actually practice the creative writing element of medicine. I know a lot of people talk shit about the EMR, but actually it's a good tool. I like the EMR. You can pull it up. I like to write notes. I like to write notes justifying my position. I like to use diagnoses. We use diagnosis codes to justify our CPT codes. I use diagnosis codes to justify my my decision making. I use the diagnoses that are present in the chart, the diagnoses that I know from my interactions with the patient, and I use them to create a narrative and say, hey, this is the reason that I cannot offer this procedure. This is what's going on with the patient, and make it clear that what you can offer them. Is this a procedure that would be better done when the patient is not acutely ill in the hospital and inpatient? Is this something that can be done as an outpatient? You have the right to offer that. Don't get pulled into a situation where you're asked to do a routine procedure on a sick inpatient. You have to always remember, the patient is in the hospital for a very specific reason. They have inpatient diagnoses. If you're doing a routine procedure on someone that has inpatient diagnoses, you're adding a level of risk to a patient that already is suboptimal because they're in the hospital. Why are you doing that? Why are you exposing yourself to that? Make a plan so that when the patient is better, when the patient is in an optimal state of health, they can undergo that routine procedure. And don't fall into someone else's checklist. A lot of times medicine, people get very fixated on executing a checklist. They think that what IR offers them is a checklist item. That's not what IR is. IR is not a checklist item. IR is a clinical decision made by clinically trained imaging physicians. We offer an opinion. Often we offer a procedure as well, but sometimes we just offer the opinion. And they have to learn to be okay with that. So, yeah, that's it's just a little bit on kind of saying no. Justify yourself, document it in the chart, communicate it with the physician. If they're not available, communicate it with the nurse, provide your callback information, try to close that loop, and make a plan. Make a plan for the future that is safe and available. And remember, protect yourself, protect your liabilities. You want to live long, you want to practice long. You want to practice 20, 30 years, unrestricted, no issues. You want to earn several $100,000 a year for several years. That is the goal of being a physician. That's one of the personal goals of being a physician. That's all I got to say. Sarel Gaur, MD.